This week on the Backtable Podcast.
If you have a fellow or if you have an assistant that can hold the end of that wire and knows how to give back tension so it doesn't move, then you really shouldn't have a problem. It shouldn't add extra time. But, you'll do it once or twice, and then honestly, you probably won't see a difference in time. It'll just be sort of checking it when it goes a little higher or lower just to make sure it's in that right space, and then deploying it. And then, again, getting used to that sort of before you pull that wire out, floral, and watch it as you're pulling that and get any tension, stopping and putting either the dilator. I've even put the sheath up to sort of unangle it just to touch the filter, and that wire will come right out.
This is Michael Barraza welcoming you to the Backtable Podcast. Backtable is a resource created by IRs for IRs to connect with your colleagues and learn tips, techniques, and the ins and outs of the devices in your cabinets. Download our free iTunes app to access our previous episodes, blog posts, and procedure-specific content to help you grow your practice. I'd like to begin by thanking Argon Medical for sponsoring today's podcast. Argon is a manufacturer of the Option Elite IVC filter, which is currently the only filter on the market indicated for over-the-wire deployment. And that's what we're talking about today. I'm joined by Dr. David Mobley from Columbia University and New York Presbyterian. Welcome, and thank you for joining us.
Thanks for having me.
I was hoping you could just start by telling me a little bit about your IVC filter placement and retrieval programs at Columbia.
It's pretty standard, and it follows the recommendations by the Society of Interventional Radiology guidelines. It's put in when indicated, and there are several indications for placement of an IVC filter. And we try to remove them as soon as possible when it's indicated, when the patients are able to have them removed.
Okay. And so, I read a poster you guys did on, placing the Option Elite filter over the wire. Could you tell me a little bit about that?
Sure. Well, for years we've been placing filters in the IVC, and we've been placing them jugularly and femorally, like the rest of the country. And the Argon rep, Mike Cucci, had come to me and said, listen, we've got this filter, which we had been using for a while. And he said, this filter is the only one that has a hole right through the middle. And he had this idea of placing it over the wire, with the wire extended all the way into either, if you're going through the femoral, up into the SVC, if you're going jugularly, down into the iliac vein, and deploying it with that wire extended all the way distally. There has been some contention with placing filters and the tilting of filters within the IVC. It's believed that tilting of the filter makes it, one, less effective in its protection from DVTs and creating pulmonary embolisms. And also it's believed that the increased tilting makes it more difficult to remove depending on how long it's been in. We had placed many of our filters jugularly and transfemorally. When Mike came to me and made this suggestion, I said, I listened to him and talked to him about the technique. I tried it a few times and it worked out very nicely. And I said, all right, well, let's take a look at this. So we did, I believe it was around 39 patients, and looked retrospectively at those patients and the 40 patients prior to that had been performed transfemorally, and looked to see if there was a difference in tilting. And there showed a statistically significant difference in tilting between the filters placed over the wire and not over the wire.
I see a lot of tilting with a lot. I'm at an institution where we have a lot of different filters in the cabinets, and especially at the time of retrieval, this is a really frustrating thing. I have used a lot of these filters, and I haven't done them over the wire. Would you mind walking me through, just start to finish, how you would place this over the wire?
Sure. Just backtracking a little bit, we also here at Columbia place a lot of different types of filters in. So we didn't know if there was a difference between just the option versus all comers. So what we did was we looked at all of the filters that we put in not over the wire and compared those to all the options we put in over the wire. And there was a statistically significant difference between the over the wire and the not over the wire for tilting. And then we stratified out just for option versus option. And again, it showed a statistically significant difference between over the wire, not over the wire. So that was really interesting and supportive of
I didn't catch that point when I read the poster. And the other thing I forgot to bring up is, it noted an increased procedure time and increased fluoro time. But, in my opinion, that time you probably save on the way out, getting these filters out, just not having to deal with that tilt.
Right. The time difference, it showed a statistically significant, although small, difference in amount of fluoro time, but it didn't show a statistically significant amount of fluoro dose.
Okay.
So that was really a little bit of getting used to the procedure and technique and getting the wire up into the SVC. So it really didn't add too much time, although it showed a statistical significant difference. The dose wasn't that much.
And again, I just think with the time saved, not having to go through advanced retrieval techniques, I think you get that time back over and over.
That's the belief, and that's what we're looking at in the coming future, and that's what we expect. We expect to make that time difference up in the retrievals. So the option filter comes with a deployment sheath, a dilator, and it comes with a pusher that has a wire extended from the end of it to about 10 centimeters beyond the end of the pusher. And that wire already goes through the end of the filter, the end hole of the filter. So you already have a wire going through it. We get femoral vein access with ultrasound guidance with a micro puncture set, and we put in a Benson wire. And over the Benson wire, we place the argon sheath. And we do an IVC gram so that we see where our renal veins are and the conformation of the IVC. After that, we put the Benson wire back into the sheath with the dilator, and we get the exchange length Benson up into the SVC. We then move our sheath up into the appropriate level at the level of the renal veins. We leave the SVC accessed with the exchange length Benson. We remove the dilator from the sheath with the sheath in the proper positioning. That dilator comes all the way off the wire. We then place the filter on the wire, being very careful to gently put the wire through the end of the filter deployer, holding your finger at the end of the filter deployer so that when you push that wire through gently, it doesn't actually push the filter out the end of the deployer. Once you do that, you grab the wire, you put your fingernail on the end of that deployer, and you bring the deployer all the way up to the sheath. You place the deployer into the sheath until it locks. And instead of using the pusher, you actually use the original dilator that you put in the sheath with. You run that over the wire, and you use that as the pusher.
I see. So
the original pusher has a wire coming out the distal end, and it has a plastic sheath used as a pusher. But what we're using, instead of one piece of equipment, we're using two. We're using an exchange length Benson, and we're using the original dilator as the pusher. We maintain back tension on the Benson wire, making sure it's still in the SVC. And that's a little bit of the added time and just making sure that wire hasn't moved anywhere. Once we confirm that that wire is still in the SVC, we look back down into the abdomen. We use the pusher to advance the filter up into the deployment area, and we maintain pressure on the forward pressure on the dilator and the wire, and we unsheath the filter in the position that we originally wanted it to be.
Got it. And so it's just the wire's kind of like a stabilizer, maintains kind of the straight position.
Exactly. So the pusher, the dilator, which we're using as a pusher, is keeping it in the position as you're unsheathing it, and the wire is keeping it stabilized in the longitudinal frame compared to the IVC.
Okay, that sounds fairly simple and easy. So really, my understanding is that you should be able to do this from really any access that you could place the filter from, as long as you have that straight longitudinal course. Is that
absolutely? You can do it from. We tried it once or twice from jugular access. We tried it from both femorals. But when we were looking at this, we really just wanted to study it from one area that most people use in the country, and that's either most people are using right jugular or right femoral. And since the femoral seemed to have more tilting, that's what we decided to compare it to.
Is this the the primary filter you guys are using, or it's just kind of a good mix?
We used to have a more of an even mix between all the filters that are out there, but with this study and with working with it, we are definitely primarily option filter, but we are an academic center. We train residents and fellows to go out there, and they need to understand how to use different filters and how they feel and how they deploy. So we do have a little bit of a disbursement between variances of filters, but primarily we're using options.
Okay. And when you're placing them personally, do you prefer to do them over the wire?
If I go femorally, then I do them over the wire.
Okay.
If I go jugularly, then I don't go over the wire.
Okay. This sounds pretty straightforward and very doable. I'm gonna hopefully have one in the next week or two. We do a surprisingly large number of filters. I'd like to be doing more retrievals. Which brings me to my next question. When you put these in, I mean, I guess it always depends on the indication, but when do you typically have patients come back for the retrieval?
Again, it depends. We try to get them back within 3 to 6 months. Okay. Sooner than that is even better. But generally speaking, with the patients that we have here, whether it's post-surgical or whatever it happens to be, they tend to need a higher level or a longer follow-out with their treatments. So for us, even though we'd like to catch them before 3 months, we usually catch them when we do, and it's between 3 and 6 months.
Okay.
For one of the most important things for the deployment, once your filter is deployed, going back to the procedure, once your filter is deployed, you'll see that it's very stable in the IVC. Mm-hmm. And so what you have is a sheath that's been pulled down. It's usually a couple centimeters below the deployed filter. Your dilator will be pretty much within that sheath or just a little beyond, maybe a centimeter below the lowest level of the legs. And you'll still have that wire up into the SVC. One of the most important things, now that we're talking about it, is the removal of that wire through that filter. What you do is you keep tension and you keep the dilator and you keep the sheath right where they are, and you gently pull down on the exchange length wire that you have. Usually it comes out with no tension. It comes out very easily. Every once in a while, the wire loops, the very small micro loops that these steel Benson wires are made of, it can cause friction on the edge of this filter. And so what you'll do is under fluoro, you'll see that the filter sort of pull down and you'll feel that tension pull down. If that happens, what's happening is you've got just enough of a tilt for there to be friction on the edge of the filter and the wire.
Got it.
So what you need to do is you need to keep that sheath in the same place, push the dilator up right into the sub-apex of where the wire goes in inferiorly through that hole, and it supports the filter, just puts it off its axis so that it takes that tension of that edge of that Benson wire off of that, and I've never not been able to pull it out easily.
That makes sense, and it's probably, with that position of your sheath, it's not going to displace the filter either. Yeah,
no, it doesn't. It's just a touch of tension, just to push it up a little bit to get it off its axis. It's slightly tilted axis, and so that you release that tension. And that's probably the crux of the very end. Because you figure you're deployed, you're done, and you start pulling, and then you can definitely pull down and cause an extra tilt on that filter.
Sure. Out of curiosity, do you do a repeat cavogram after filter placement?
I do them regularly, yes.
Okay. I'm just curious.
I did it every time when we were doing this study. Subsequently, some of my partners who I have taught the procedure to, some of them do it and some of them don't. I routinely do, whether I go jugularly, over the wire, not over the wire, or transfemorally, I routinely do a post-positioning cavogram.
Okay. All right. Well, is there anything else you'd like to cover?
No, I think that's it. That goes over it. Just a reminder that, we did stratify for the non-filters over the filters. It is on the poster. It's in this section under the results in the subsection that we compared option to option, and it did show still a statistically significant difference between tilting with and without over the wire using a transfemoral approach.
Yeah.
But if you are going to go transfemoral, I use over the wire, even if the IVC looks quote unquote straight. I mean, I'm sure you've been in a situation where it looks straight, it pops out, and then it just bends right over, and you're just exactly. Now, the interesting thing is, if you go right, we did all except for one of our filter placements from the right, and there was a statistically significant difference tilting toward the left. You have that angle that's going over and it's bending over against the left side of the IVC. Mm-hmm. The one we deployed from the right, from the left, tilted over toward the right. So even though there was only one and we didn't have any power to compare the two, it just makes sense that these things, you come in from the right, it bends over, it's leaning oftentimes to the left side of the IVC, and that's the side they tilt on. That being said, if I go femoral, left or right, for any reason, I go over the wire.
I'm going to give it a try. I mean, we are doing a lot of filters where I am now.
Yeah.
And I may be able to do it next week.
It's a little bit, if you have a fellow or if you have an assistant that can hold the end of that wire and knows how to give back tension so it doesn't move, then you really shouldn't have a problem. It shouldn't add extra time. But, you'll do it once or twice, and then honestly, you probably won't see a difference in time. It'll just be sort of checking it when it goes a little higher or lower just to make sure it's in that right space, and then deploying it. And then, again, getting used to that sort of before you pull that wire out, floral, and watch it as you're pulling that and get any tension stopping and putting either the dilator. I've even put the sheath up to sort of unangle it just to touch the filter, and that wire will come right out.
I'd be interested to see, how large the hole is. If it'll only fit, we're talking 035, or could you put an 038 wire in?
I think you can put an 038 wire in, yes.
Interesting.
I tried it. I tried a few of them with the stiff amplats and with a exchange length, and it worked just as well. I didn't see any difference, and since I had already started with the exchange Benson, I just kept going with that. But the stiff amplats works very nicely as well.
It's awesome. It's an innovative, useful technique. I look forward to doing it myself. I also look forward to seeing, the rest of the data that comes out as you guys look at the retrieval times as well.
Yeah, we're looking forward to that.
And lastly, I'd like to again thank Argonne Medical for sponsoring today's podcast. Again, the Option Elite filter is the only one on the market currently indicated for over-the-wire deployment. Thanks everyone for listening in. Bye.
Thanks. Bye-bye.